Good morning, everybody. Dr. John Willardsen here, Trust Implants, trustimplants.com. I'm with my compadre, Memo Hea, and we've got a great show today for you guys, great live stream. This week we've had a great week. We've done a lot of really nice cases. A couple of those I'd like to show you to talk about. We get questions from some of our viewers, and by the way, we are so grateful for our viewers. And last week we had a bit of a technical difficulty with our Wi-Fi. It went down. We continued to talk and were sharing, and then all of a sudden realized that 15 minutes in we weren't live anymore. So apologize for that. But hopefully today the Wi-Fi will work just wonderful. You'd think in the middle of Southern California, Newport Beach, you'd have perfect cell service, perfect Wi-Fi, but it's just not the case. I have Verizon and I get, half the time I don't have signal. So anyways, yes, we've got a great show today for you guys. I'd like to look at, first of all, take a look at a TikTok that I... Hold on just a second. Oh, there we go. Okay, so, as I've been looking at some of the dental implant content on TikTok and on social media, Instagram and Facebook, there's quite a few, and it's a good forum because it's real people with real situations, real problems that are sharing their experiences in different settings, different practices, whether it's a corporate practice or private practice. And as I talk about a broken system within the implant world, it shows, it's very evident because these are real stories. And as patients share their stories and share their experiences and are finding that, the costs for the procedures, when they get into the office, they're quoted a certain fee. They, kind of pull them in under a certain guise of like having a full arch done at $19,000 or whatever. But then soon find out that, that doesn't include grafting or alveoloplasty, which is a term we'll talk about, or sinus augmentation, or, we're going to upgrade you to a zirconia prosthesis. There's just a lot of different ways that it can the rails kind of fall off as the patient moves along the process. So, here we try to, and even here sometimes we have cases where I get into the middle of it and, things can deviate. But I try to mitigate those situations before doing the procedure. So, and that's one of the reasons why over the phone, patients will ask, what's the cost? And that's, of course, we want to share the cost with the patient. It's not as if we're trying to hide something, but it's kind of like, if you want to build a house, what is the cost of a house? Well, how many square feet is the house? How many rooms does it have? How many bathrooms? What are the finishes? What's the material of the finishes? Is it all the finishes and faucets and sinks and furniture? Is that coming from Home Depot, or are we going to, a Pottery Barn type situation? So at the end of the day, and this similar like a house, it's what kind of outcome or quality, or because like a house, this is something that you have to live with and deal with for the rest of your life. So how it feels, how it functions, what's the occlusion or the bite like, what are the aesthetics like, what's the material made of? There are so many variables that it is very, very difficult to, over the phone, quote a price or quote a fee. We do know it's an investment. And I've said in previous live streams, if you were to lose an appendage, lose an arm, lose a leg, what's the cost to replace that, arm or leg? What would be the value to you as a patient to have that replaced at about 90% of function, to where you can utilize it, you can pick up your phone, you can dial with your fingers are working. What is that worth to you? And because our mouth is truly that. It's essentially like an appendage. And once we lose it and lose the ability to chew, eat, speak, have confidence, smile, and not feel inhibited when we have interactions with people that we meet, there are so many aspects of it that, for somebody who has their teeth, they don't think about it. But for somebody who's lost or losing their teeth, it's the only thing they think about. And so I'd like to look at, first we'll take a look at, this is one of the reasons I came up with this, kind of wanted to talk about this, is one, we get a lot of questions on our channel. And also, also when patients call in, first thing they'll ask, how much is it? And of course, we want to answer that question. And we don't want to, act as if we don't want to answer it. It's just, I need more information. What type of case is this? Are we extracting all the teeth? Are we grafting the sinuses? How much grafting do we need? There's just so many variables. And so we'll take a look at this. This is a TikTok, and this young lady who obviously, and she's very young. I'm quite surprised and very emotional. You can see, I can't imagine, I would imagine she's probably, under 30 years old, so maybe 25, 6, 7, who knows. And to lose her teeth at this stage in life would be a real travesty. I can't imagine, losing my teeth because, again, removing her natural teeth, she will be aged 15 years in a matter of 20 minutes. So she'll look a lot older once those teeth are out. Luckily, she's got nice skin and she's, still has youthful looking eyes and hair and all that. But once those teeth are out, she will be aged a good 10 to 15 years right off the bat. And so she's talking about all the different fees as she's looking at her treatment plan. I assume, I'm kind of guessing here, and talks about the extractions and the cost for extractions, and then the bone grafts and sinus augmentation, the alveoloplasty. What is an alveoloplasty? Well, I'll show you in a video here in just a second what that means. And for the corporate all-on-4 centers, they do a lot of, alveoloplasty is the reduction of bone. So they cut down the bone to a certain level in order to create space for the set of teeth that are going to go onto the implant. So they'll cut the bone down, place the implants, and then the alveoloplasty is cutting down the bone, and then that creates space for their prosthesis. The reason that they have to cut down so much bone, oftentimes we'll see that they'll cut down about 10 millimeters of bone in order to provide strength for a plastic or hybrid prosthesis. So the teeth themselves that they make when they cut down that much bone is a titanium framework wrapped with plastic and denture teeth. And so here she's kind of talking about how much money she's spent and still not completed. So she's into it about $33,000 and 12 months. So you got the time and the money spent and still kind of stuck in the middle. And this is really a great example of why I say this system is very broken. If you've got one doctor placing the implants, another doctor restoring the case, and there's lack of communication there, or they don't know what type of materials they're using. So if the surgeon placing the implants isn't really sure the type of bridge or prosthetic that's going to be used or made, the materials used, the placement of the implants in that situation is very different. Whereas, here we insist on a minimum of 6 implants. I do minimal alveoloplasty, minimal reduction, because I don't need 10 millimeters of strength or support in order to support a fixed zirconia prosthesis, which leads me into, having cases where there's no gum tissue at all. Here is a fixed upper zirconia bridge, and I kind of use this as a thumbnail on a lot of these, and there is pink porcelain. There's This patient had a lot of gum or periodontal disease, bone loss, and I needed to use pink. Otherwise, the length of the teeth would be all the way from the top of the bridge down to the edge or the incisal edge of the tooth. So that tooth would be very long. So we oftentimes will have to use pink porcelain in order to make it look natural. And it really does. Some patients are adamant about no pink porcelain. And so the placement of those implants in a case where I'm using no pink at all is very different than a case like this where I'm able to use the pink ceramic material. Again, there's no plastic in this bridge. It's all zirconia and no plastic at all. So,
well, doctor, going back to, I guess, the price that we were talking about, and then also in this situation, with this lady, having the oral surgeon place the implants and then the prosthodontist do the prosthesis, it's so easy to point fingers when there's two people involved, right? Because if something goes wrong, like, who's she going to go to? Like, the prosthodontist, and he's going to be like, oh no, it was this guy over here. Mm-hmm. And so they go everywhere, right?
Yeah, that's exactly right. So what they'll do is they'll say, well, that's where they told me to place the implants. They'll, and we just finished a case, and this poor guy, Matt, who comes from Ohio, fell right into that situation where it's like, well, the surgeon told me to place an implant here, but and we've shown his case, so not to kind of belabor that, but if the general dentist or even a prosthodontist is telling you to put an implant in the midline, as a surgeon, you don't just follow those guidelines. You're like, well, that doesn't seem right, because I know a tooth doesn't necessarily need to go there, like right in the middle of the nose, right? And that's an implant that I had to remove. So the surgeon needs to understand the prosthetics and what material is being used and what's the final outcome, so that I can place these implants accordingly. And, and that's where, you're right. There is finger pointing back and forth on those cases that don't go very well or go smoothly. And it's not that there's that many of them, but when there is, it's a big problem, right? The patient's the one that suffers. They're the one that's going to have to deal with the ramifications of removing implants or getting something that they really didn't sign up for. And again, it's like I said in the past, you don't know until the case is completed, and then you're like, oh, wait, I don't like this, or I wanted this, or this is kind of what I was thinking. And by then it's too late, Yeah.
Well, also, because this is something that we talked about last week, but you only talked about it for a little bit of time. And I've had questions being asked about this. But another thing that goes into the price of something, because like you said, when they call and they say, well, I want to know an exact price, the range of that price is so big that
it varies quite a bit.
It's like if you give them, like, it's even hard to give them a ballpark, because you don't know if there's still enough bone or there's plenty of bone. And then one thing, like I said, we talked about last week, that patients don't understand is that if there's active infection.
Right. Yeah.
And so, correct me if I'm wrong, but if there's active infection, we start treating that before surgery, right?
Yeah. So let's take a look at this x-ray here. This is a really good example, because this is pretty much exactly what we talked about. And this is actually a surgery I did yesterday. So, and again, I apologize for just going off of x-rays, but that's how I view the world, unfortunately. Patients will say, do you remember so-and-so? And I'm like, oh, gosh, I don't. Show me their x-ray. And as soon as I see their x-ray, oh, yeah, I remember them. So here we have a situation, and you can see where the bone is at the tip of the root. So this is bone up here where it's a little dark or lighter, and then it's migrated its way down to the tip of the root, or the apex of the root, even around these molars on this side, over on both sides actually. So these teeth, literally, I could take them out with my fingers. In fact, I was not able to make, normally before we start a case, we'll make an impression so we can start the fabrication of the teeth, right? We make impressions, start kind of diagnosing, treatment planning, designing the case in CAD so we can, on the day of surgery, have everything ready. But in this case, I couldn't do that because had I made the type of impression that I make, I would have pulled out the majority of her teeth. And she did not want to go. And it would have been a few weeks that I would have been able to actually get her in and get her scheduled and do the surgery. So I did not make the impression on the pre-op or the day that we started her case because of the fact that I would have lost so many teeth during that process. So, which tells me, obviously if I were to make an impression on your teeth, they're not going to come out. I mean, they're in there nice and solid. But so this is a severe periodontal disease situation where the teeth are so compromised because of lack of hygiene, brushing, flossing. And again, like I say, the body now is rejecting these teeth. It's excreting or expelling or whatever you want to call it, eliminating the tooth because that is now the cause or the nidus of the infection. So, our bodies are remarkable organisms, and the process of even this is quite remarkable because at one point these teeth were very solid in the bone, but as bacteria, debris adhered to the tooth, developed and kept growing on the tooth and was not removed, the bone's like, all right, this is now a foreign object and I want it out. And so the bone starts to pull away and then ultimately the teeth are removed. So this is a severe periodontal disease case. Now, this patient had gone to multiple corporate offices, was diagnosed an all-on-4, upper and lower. But as I look at her CAT scan, here's kind of the before photo. And you can see how much bone loss there is here. So we've got a lot of bone loss here in the front of the jaw and what we call the premaxilla. These teeth are completely mobile, loose to, I can wiggle them around. I could actually, this canine here I actually pulled out with the impression. And then here's looking at some of the CAT scan images. And you see these what we call radiolucencies, this darkness around the apex of the tooth. There's nothing holding it on except for gum tissue. And here's the designing of the case. So as I'm looking at, this isn't active right now, but I can move this on my CAT scan. I can move this model around. I can look at the sinuses. I can look at this red line down here. That's the infraalveolar nerve. I can see where the nerves are, the sinuses, and do all those things that I need. And here's the design of placing the implant around the nerve. I can determine the width of the implant, the diameter, the length. I can know where the nerve is, what my clearance is above the nerve. So I'm able to plan these cases out to exactly as they should go. And then it's up to me to execute this in surgery and to do these procedures while I'm in the surgery. So we'll take a look at... And so here we are in the upper jaw. We've got a lot of bone loss here around this implant, but I do know how much bone I have to work with. This implant will enter into the sinus. It will require grafting and a technique that I use to place implants in the sinus and in areas where I have bone that's not quite as dense as other areas. Like for example, on the lower, every single one of these implants after I did do an alveoloplasty, removed just the minimal amount of bone, not I just had to smooth off the ridge, but every single one of these implants had 70 plus Newton centimeters of torque. They were in there very, very tight. Whereas here, I have to use a different technique. I need to kind of be more delicate, expand the bone, and place the implant I under-prepare the hole or the osteotomy so that implant will drive in and I'll get as much torque as I possibly can while also doing what's called a sinus lift. So different techniques that I can use in different scenarios, and it's all, again, it's like flying an airplane. You got to navigate yourself according to the winds and according to the elements and the weather and everything. So... And for us, it's according to the available bone and the infection, the defects in the bone, and then just fixing this to the most ideal situation. So, and that's why it's difficult to quote a fee because, we can't know in fact, I can even see a patient, like this, look at an x-ray, look at a panoramic x-ray, take a full mouth series of x-rays. But until I'm actually physically in there and doing the surgery, I gain a lot more information. I'm learning, what the bone density is like. After I've removed the teeth, how much granulation tissue or infection do I have? And it's not until I'm in this scenario that I really even know, okay, this is really what I need to do for this situation. So in this video, you can see how easily these teeth are coming out. I mean, they're just literally just popping out like, very, very easily. So that's due to just periodontal disease and, neglect. And I get it. At a certain point, patients get to the point where they've lost a bunch of teeth, their bite is off, they're not happy with the way things look, they lost a lot of confidence in their smile, and so they just give up. They don't, they just basically just give up. And here what I'm doing is, now that the teeth are out, I'm reflecting the tissue. And this is an important part of the process because it's a very delicate procedure to reflect that tissue, get into removing what we call the periosteum. So you're separating the gum tissue from the bone. So I'm looking physically directly at bone that has no attached tissue on it. Right here, I'm doing a sinus lift using osteotomes and a graft, and also placing an implant. So, this is, again, I'm navigating this case according to what is best for her as a patient. And a lot of this I assumed at pre-op, but now I know. Now I know how much torque I have. Now I know where these implants are going and have to go. But I also know the type of prosthetic that I'm going to be using in her case. So, a little bit graphic images, but this is the reality. This is what it takes in order to do these cases. And there were a lot of defects in the bone as once I pulled the teeth out. And I'm filling those defects with graft material and, of course, placing implants at the same time. And, kind of when we started looking at this case, I was talking about she had been to 4 different consultations regarding the all-on-4, and she's just not a candidate for that. They would have been very surprised after they opened this case up, and thought, oh gosh, where am I even going to place these implants? Because with the all-on-4, they're not grafting. That's not part of their protocol, is to do a lot of bone grafting to fill in the voids in order to provide good long-term success. So in this video right here, we've got implants placed, grafts in place. I'm putting a membrane. So this membrane, what it does, and I'm hydrating the membrane, you'll notice, with a antibiotic. So it's I'm sterilizing the area using antibiotics and really making sure. And this is how we have such great success here, because all of these steps are very, very methodically thought out. There's not one thing that I do on a case like this, or on every case, where I'm not maximizing and helping the body heal the best as it possibly can. I'm giving it both everything from graft material to membranes, and how I hydrate the bone, and the type of implants, and the design of the case, and preparing the osteotomies or the holes, and getting good torque on the implants. So every single step that I do, I'm maximizing the outcome, so that when it's all said and done, this case is going to work beautifully, and it's going to be one that will last her the rest of her life if it's maintained. Now, of course, if she doesn't fall back into those habits that caused her to lose her teeth, she will have absolute knockout success with this case. So here we are going down to the lower. The teeth are out, and I'm just making an incision, reflecting this tissue back. It's, again, very, very important to reflect the tissue down to beyond the periosteum and bone, so that we have bone and tissue that's fully separated. And inside a lot of these extraction sites is granulation tissue. That too has to be removed. So when I talked about the alveoloplasty, that's this right here. Just literally just smoothing out, contouring the ridge. And for those who have not seen many surgical videos, she's under general anesthesia. I also give her local, so a lot of local, Marcaine. And so there's just no way that she's feeling any of this right now. So she's intubated, and then, as the patient is asleep and we're monitoring her, we can see if even though she's asleep, we can tell if she's feeling anything at all, even remotely, because her blood pressure will go up a little bit. But she's not feeling anything at all. Her pressures were totally fine throughout the entire procedure. And to remove bone, to do the alveoloplasty as I'm doing here, it's also not painful. There's not nerve endings that she would be feeling this. But it's important to have a nice smooth ridge. But you'll notice I did not remove a lot of bone. I only was contouring bone, smoothing the bone off, because I want to maintain as much bone as I possibly can. And then I'm starting the holes for the implants here. And at each step, especially over the nerve, I stop at a certain point, take an x-ray, and make sure that I'm clear of that nerve. And once I know that I am, then I go ahead and I open up the aperture of the hole or the osteotomy, and then I will go ahead and place the implants there. So, and this is where we're placing here. It's a little bit hard to see, but.
So, doctor, going back to, because you did mention that there was some infection in this case, right?
A lot of infection, yeah.
A lot. And is that something that we start treating before the surgery, right?
Yeah, so we put them on antibiotics before. So if we look right here, this hole right in front of where I'm placing the implant, you see that little defect? Or right here. I mean, that's all infected tissue, or it was infected. And that's a great question, because where you saw that hole, it was filled with infectious, what we call granulation tissue. And so I clean all that out. I scoop it out and really get down to solid bone. And so by doing that, I've removed the infection. It's completely gone. One, by removing the tooth and also removing the granulation tissue. And I'm filling that tiny little hole right now with graft material. And so all of that's going to be filled in. The bone will be leveled off, and the infection will now be gone, because one, the cause of the infection is gone, and also the defect in the bone is gone. We also had to extract a wisdom tooth number 17 and left a large defect in there. So here we're just kind of manipulating the graft, taking graft material across the entire ridge, and then also laying down a membrane to separate the gum tissue from the hard tissue or the bone. So,
well, I'm just thinking, like, from the all-on-4 center perspective, it wouldn't be worth it for them to do all-on-6, all-on-8. If they're
it's too much work.
It's too much work for them.
It's a lot of work.
They're going to pump them out quicker,
Yeah.
So,
and not to mention, a lot of times they don't even raise a flap like this. So they're not, they are not actually. If I don't reflect that tissue off, even though it's a little graphic, if I don't do this, take the tissue all the way off the bone, get a physical, solid look at the bone, wherever there is a defect in the bone from the infection or an infected tooth, and clean that up, that infected tissue is just going to stay there. And most of the time with all-on-4, they use a guide, like a guided surgical guide, and they depend on that guide, and they just drill right through the tissue and then place their 4 implants with no regard for the fact that, we want to clean up those defects. We want to, I'm going to just go back here because I'll fast forward, but we want to clean up the defects that are left behind underneath these extraction sites. I don't want to leave that granulation tissue in there, because it'll just continue. It'll remodel, but it's going to, meaning that it'll turn into bone, kind of, but it's going to shrink the bone to the point where there won't be any bone left. So whereas if I, reflect that flap back or that gum tissue back, clean out the hole of where the infection was, clean out that infectious tissue, and do a bone graft and do a membrane, now I'm reestablishing and rebuilding that ridge so that we're just going to have a much, much better long-term result. And again, this is where we just simply cannot, quote a fee over the phone. We can get close, we can give a ballpark figure, but there's a lot of variables, and this is all for the good of the patient. It's nothing to do with, trying to, get rich off of this, because I'm certainly not doing that. But it does provide the very best service, the best outcome for patients that are in need of this sort of treatment. So, but yeah, you're right. I mean, we're treating the infection, and also we're treating the cause and the negative effects of the infection by doing a bone graft and rebuilding the ridge and cleaning out that infection 100%.
Well, I'm just thinking with infection, and that has to be treated, you give medication so they can take it a couple weeks before antibiotics.
Yeah.
With infection, and then the grafting and all that, and then the recovery, like for everything to get back to normal, right? And then be able to place a prosthesis. I'm just thinking, how can that be done in 24 hours?
It's mind-boggling. It really is. I know they get away with it at a certain level, and it's a great marketing tactic, but it's just, to me, in my practice, in my hands, and with my patients, it's just not something that I would hang my hat on. It's not something that I would promote for everyone, that it's the best way to go. It's an investment, no matter how you slice it. But if I'm going to make an investment such as this, and I want it to be secure, I want it to last, I want it to be something I can count on, and to do this delicate, highly intense, highly predictable procedure and try to do it in 24 hours is, I don't know, honestly. It just kind of blows my mind, and I just think, man, I've worked way too hard and have put in so much into this that I would never compromise my patients to that level and just say, let's do this in 24 hours and call it a day,
Yeah, that, and then also the fact that, any general dentist can take a weekend course and be able to sell this legally, right?
Because and there are some general dentists, I assume, that are pretty good at it, that have gotten enough cases under their belt, I suppose. Like, for example, the company that promotes the complete final prosthesis in 24 hours. So I'll back off of here. So, and I'm not going to say any names or talk about any names, but this is from an Instagram post from one of their patients. And just and you're not even really a lay person anymore, because you know a lot more about this than most dentists. But when you look at this photo, tell me what you see. What does anything in particular stand out to you? In looking at his teeth, just his teeth, does something stand out or just not look right?
I don't know. Maybe the smile looks a little weird.
Why does it look weird?
It's just not showing the top part of his teeth.
Thank you. So the smile line, the curve of SPE, he's showing so we have something that's called golden proportions. So what that means is that the upper teeth, like when you smile, you have golden proportions, or when I smile, I have golden proportions. The upper teeth proportionate to the lower teeth are in that golden proportion era. So I'm showing like 3/4 of my upper teeth and about 2/3 or 1/3 of my lower teeth. I'm not showing more lower teeth than upper teeth. In this case, he's showing so much of his lower teeth that it looks like he's kind of doing this. That's basically what you're seeing here.
It's an upside down smile.
It's an upside down smile. That's exactly what it is. And the video of him, he's just elated about his new smile. He's elated about having his teeth done in 24 hours, and I came in and the next day it was done. But you're getting this kind of result? Mm-hmm. And you're like, that's the final? You're stuck with that? again, you cannot be the morals that we have to have when we're doing these procedures. And I had a patient the other week, that, as I was doing his case, because one little thing was off here or there. And he's like, "Doctor, I'm so grateful that he's like, so many times I just wanted to be done, but you just kept making changes almost to the point where I was like, oh, come on, this is good enough, right? But I wanted it to be absolutely perfect because when it's done, right? And there's no way I would send a patient out the door looking like this. There's just simply absolutely no way. But that is my moral compass. That is my integrity. It represents me. It represents my practice. It represents my skill set. It represents my profession. It represents my training. And so if I send a patient out looking like this, I have failed. I have completely failed, and I do not know what I'm doing. And that, to me, is what this screams. It just screams. If the doctor didn't see this, it's like, oh, it looks fine, whatever. Next,
Yeah. You know what? It almost looks like the before picture of someone.
Right? This is the after.
And that is the after. But he probably doesn't know any better,
He doesn't know any better. He has teeth now because he probably had, something like this. So, of course, that's not his pre-op photo, but he probably had something along these lines. And, to have this, it's like, oh, gosh, I don't know, looks pretty good to me. I mean, I'm not a dentist, but
you can eat now.
I can eat, and I have teeth. I have a reverse smile. It's upside down, but it's, and I got it in 24 hours. So, hey, I'm a happy camper, but it's a catastrophic failure. 100% catastrophic failure, and the doctor should be ashamed of himself for having delivered this and just said, okay, Mr. So-and-so, you're good to go. You look great. And then, Miss Jones, come on in. Let's finish you up. And that's just not me. That's not what I do. That's not what I would just never do that. I couldn't sleep at night. And
well, that, and then also just the number of patients that they see in a month compared to us is, we could only see so many patients 1 month.
Yeah.
You only have so much time. Yeah. And like you just mentioned that you had surgery yesterday and then you have surgery right after this.
Right now.
So we're going to wrap it up soon and we can cover the comments next time. But what I was trying to get at was that, yeah, that's their goal, is just get as many people as they can. And we literally tell people on the phone, like, hey, well, first of all, for the consultations, you got to make sure you make it because we only have certain days, like 1 or 2 days a week to have 5 consultations, 6, 8 at most, right? Mm-hmm. And then also just how the number of patients that you can see a month, because you take your time. It's not a 24-hour process. It's a multiple visit process. Yeah. And it requires time and attention. Like you said, sometimes things could go wrong. And imagine if something goes wrong, but hey, you have to do a surgery in 2 hours. Are you really going to dedicate the time and attention that this surgery needs in order for the case to be successful afterwards? Like, probably not, because Ms. Jones is coming in and she wants her smile in 24 hours.
Yeah.
Right, so
yeah, that's exactly right. So, and then on the cost, for example, the teeth in 24 hours or smile in 24 hours facilities, in order to generate and do that volume of cases, they have to be a lot less expensive. I don't know what their fees are. I would imagine it's probably around $25,000 to $30,000 per arch. But I don't care if you're spending $30,000 an arch or $25,000 an arch, or you end up spending $60,000 or $70,000 for the whole case. Whatever amount of money that you spend, if he spent even $50,000 for this case, that was money lost. 1, because he got it all on 4, and 2, the outcome of this is, I don't even know. It's not good. And then also the materials that were used. I don't know the materials you used, so I can't even speak to that. But if it was a resin-wrapped hybrid with plastic teeth and and plastic resin on the pink with a titanium framework. And he spent 50 grand and he got this result with 4 implants, upper and lower. The doctor made a ton of money and the patient really lost because the end result is not great. And also the materials that were used, the number of implants that were placed is totally subpar. And who knows the type of materials used or implants used. But as you look at these places that are offering, $20,000 an arch or whatever, I can guarantee you they're not using the very highest quality implant and they're not using the very highest quality materials for the prosthesis. And they simply cannot take the time necessary to make it absolutely perfect. And you end up with situations and results such as this.
Mm-hmm. No, yeah. It's definitely something. And again, we keep mentioning it. We continue to create these videos, these live streams to create that awareness so people can get educated. Just to cover, I guess, lastly, a comment that relates to this. I can't find it, but I'll just kind of, from what I remember, is basically someone was saying that people who are just doing these cases without any training should get their license taken away because they're just doing it to basically make money from the patient, not really know. I feel like some of these dentists don't even know what the better options are.
Yeah, I mean, for sure, there has to be some regulatory body, which there is not and there never will be, within the American Dental Association or California Dental Association, which falls under the American Dental Association. There will never be a regulatory body for these types of procedures, implant cases in particular. And let me explain why. You've got too many cooks in the kitchen. You've got oral surgeons are never going to give up their place in the implant surgery world. They don't want to delve into the prosthetic world because it's not their world and they don't understand it. Periodontists are never going to give up their place in the implant dentistry world because they want to place implants. But again, they're not trained in the prosthetics, so they can't deal with that. They don't even know how to deal with that. Same with oral surgeons. Prosthodontists don't know how to place implants, so therefore, and they're not going to want to give up their piece of the pie in the prosthetic world and making the teeth and the prosthesis. And then you bring in a general dentist who's like, wait, I can go to Mexico, I can do a weekend course. Anybody can place implants. I mean, as a resident, they would say you can train a monkey to place an implant, but that's not necessarily true because it's a very technically demanding procedure to place the implant, to manage the case. That's just on the surgical side. So the grafting, extractions, management of the bone, management of the hole that we make or the osteotomy to place the implant, how the implant drives into the bone, the diameter of the hole that you use for that particular implant and how it engages the bone, how much torque you get on the implant, and then how you graft the case and then grafting the sinus and then how to close the case up, release the tissue, suture the tissue, use a membrane. That's all surgical. And then you get into the prosthetic side of things and a general dentist is like, well, I can drill a hole in the bone, I can place an implant, so I'm good there. But now the prosthetic side of things, well, I'll figure out the prosthesis because I do fillings and crowns all day long. So I should be able to figure this out too. So that's truly the wild, wild west. You have all these people that or all these groups or specialties, general dentists and other specialists that know the value of an implant practice or implant patients. And so they're never going to let go of that. And as a result, and on the board, so within the ADA, you have a specialist representing each group. So oral surgery, pros, perio, general. And so they're all just kind of biting for a position at the table. So in the end, and it's why I say the system is broken and it'll never be fixed because there's no regulatory body regulating the surgical aspect and the prosthetic aspect. Patients want teeth. Of course, they need implants because that's what's holding the teeth. But the implants is kind of like what kind of brakes do you have on your car, right? I mean, you know, the brakes have to work and they got to work functionally, but at the end, you want the car to be able to function, drive, and stop, right? And so at the end of the day, this broken system is going to continue to be broken, and the patients are going to suffer because of this, I guess you would say, political environment that we're in, and those politics are going to continue to grab onto and hold on to their little niche of implant dentistry. Half of them don't understand the other half, and the other half, so the surgeons don't understand the pros, and the pros don't understand the surgery, and so there's a huge disconnect, and that's where I come in. Trust Implants. I'm trained in implant surgery and implant prosthodontics. I do the whole case, very well versed in the entire process from A to Z. There's not a case I haven't done or seen over the last 22 years, and so that's, if I have to fill that void for right now, because it's not going to happen within the political side of things, then me and my practice will fill that void. Mm-hmm. And I'm not saying this from a pride standpoint. It has nothing to do with pride. It's just a matter of what I see when I have a patient who starts and finishes, the outcome we're able to get, and then the countless cases that we see that are failing, that are broken, that are distraught because they've lost a ton of money, they've lost time, and their cases still aren't finished, and so they end up here, and we just go, okay, just all right, let's start from scratch and let's get your case done. And but unfortunately, you've got these big box corporate centers that are still promoting and pushing teeth in one day, so yeah, it's I don't know, get a little over passionate about this, but at the end of the day, I feel good about my cases. We have amazing patients, amazing outcomes, and so that's what allows me to sleep well at night.
Yeah, of course, yeah, and thanks to again all of our viewers and then the people who have commented on our YouTube channels.
Absolutely,
little by little,
very grateful. We have the best patients and grateful for our viewers, and yeah. Little
by little, we'll continue to answer those your questions. We try to keep each live stream, every video, to answer multiple questions that have been asked on our YouTube channel. So thanks to our viewers. So.
Yep. So another week gone by, and we appreciate our viewers. Continue to like our videos and subscribe. Helps the tube to get more views on our videos and content. And again, we're talking about things that no one really cares about unless you need it. And so Memo and I and Dennis are the technical guy in the background who makes all this happen. Grateful for them and also our viewers, and for my patients, my practice. Most importantly, I'm grateful to God because He makes all this happen. So I'm Dr. John Willardsen here with Memo Hea and Trust Implants, trustimplants.com. Subscribe, like our videos, and we'll see you next week. Have a good week. Thanks.
Have a good week.